heartfelt thanks for accepting this invitation from NBES and DNB board and the students and myself. Zalak is an exam-going DRNB surgical onco. She's going to present a case of thyroid today. And please utilize this opportunity very well because now everybody is having exam this month. And that's why I've shifted the gear and moved for case presentation and use the chat box and Q&A. Put relevant question that is important for you at the end of it. In the given time, it will be answered. Professor Arnab Gupta has a academic session in a big congress, so he'll continue as long as it is permittable for him in the last couple of minutes. If we lose, we know these commitments. Thank you very much, and over to you, Zalak. Please start.
Good morning, everyone. I am presenting case of 29 years male who is residing at Surat, Gujarat, and who is working as housewife. Presented to us with chief complaint of painless swelling in front of neck for past 1 year. My patient was relatively asymptomatic before 1 year. Then she noticed the swelling in front of neck, which was insidious in onset, and initially it was approximately 2 into 2 centimeter in size, and gradually it increased up to present size, which is according to patient double than the previous size. There is no history of fever, cough, or weight loss. There is no history of.
Yeah. Did the patient tell you it was 2 centimeter in size, or did she describe in a different way?
No, sir. She was educated and she said around 2 centimeter it was, and now it is almost double.
Okay. Fine.
So, Zalak, I'm sorry. I think my video is not working. Am I right? I think I'm not visible. No, is it so?
No, we can't see you.
Yeah, I'm sorry, but somehow it's not working. But anyway, Zalak, you said that there is a swelling in the neck for 1 year.
Yes.
Is it so?
Yes, sir.
And there is no other relevant symptoms the patient complained you?
No,
except
sir.
Increase in the size, which has gone up to the double.
No, I think she is now describing that. So
right. Okay.
Let's proceed.
There is no history of fever, cough, or weight loss, or voice change, or difficulty in swallowing or breathing, or facial edema, or there is no history of any other similar swelling in neck or symptoms suggestive of hyper or hypofunctioning of thyroid gland. There is no history of chest pain, hemoptysis, any bony pain or bony swelling. Should I proceed?
Yes.
On elaborating past history, there is no history of suggesting of diabetes mellitus, hypertension, or tuberculosis in past. No significant past medical or surgical history, and patient is not on any medication. There is no history of radiation exposure. My patient is consuming mixed diet with unaltered sleep, appetite, bowel, and bladder habits. Her menstrual cycle is regular, painless, and for 4 days every 30 days. She gained menarche at 13 years of age. She is gravida 2, para 2, abortion 0, and live birth 2. Both children were full-term vaginally delivered. Her last menstrual period was before 10 days. Her family history is non-contributive.
So, what sort of family history do you ask for?
Sir, I have asked for any thyroid condition in family or any malignancy pertaining to thyroid, breast, or any other malignancy in family.
So, what are the family history, the syndromes that you know of where family history is kind of relevant?
Sir, family papillary for papillary thyroid cancer, there is familial papillary thyroid and renal cancer. Then Cowden syndrome. Then FFP associated malignancy.
Okay. Right, please proceed.
So, on general examination, I have examined my patient in well-lighted room with her verbal consent. My patient is conscious, cooperative, well-oriented to time, place, and person. She is fairly built and fairly nourished. Her BMI is 19.3 kilograms per meter square. Her ECOG performance status is 0. Her vitals are within normal range, which is temperature is normal by palpatory method. Pulse is 72 per minute in right radial artery, which is regular. Her blood pressure is 100 by 70 millimeter of mercury in right brachial artery. Her respiratory rate is 16 per minute, which is abdominothoracic. There is no signs of pallor, icterus, clubbing, cyanosis, generalized lymphadenopathy, or pedal edema. There is no signs of hypo or hypothyroidism, and her back and spine is normal. On local examination, I have examined my patient with slightly flexed neck in sitting position. There is approximately 4 into 3 centimeter size swelling in front and just left side of midline in the region of thyroid, and which is having smooth surface with well-defined superior, medial, and inferior margin, and ill-defined lateral margin, which moves with deglutination and does not move with protrusion of tongue. Skin overlying swelling is normal, with there is no scar, sinus, or dilated veins or any pulsations over the swelling, and there is no other visible swelling in the neck. And oral cavity examination is normal.
Do you think this, looking at it, do you think this patient has got retrosternal extension, or is it just limited to what you said?
Sir, as I can see inferior margin, it is less likely that it has retrosternal extension.
Right. How would you confirm clinically?
So clinically, by getting below the swelling, I can confirm.
Anything else? Any sign you know of?
Or sir, Pemberton sign, I ask patient to lift her both upper limb and touch both ears and wait for 1 to 2 minutes. And if there is distress or facial edema, there is sign of retrosternal extension.
Okay. Right, carry on.
On palpation, temperature overlying swelling is normal and swelling is non-tender. There is single oval shape 4 into 3 centimeter size swelling in anterior and just left to midline of neck in the thyroid region, left lobe of thyroid region. It has smooth surface and firm in consistency with well-defined regular superior, medial, and inferior margin. Laterally, swelling goes behind the sternocleidomastoid muscle. Getting below swelling is possible, and overlying skin is not fixed. Trachea is centrally placed. Bilaterally normal carotid pulsations are felt, and there is no palpable lymphadenopathy in neck. On percussion over manubrium, there is resonant node. On auscultation, there is no abnormal bluish heard over swelling. Other systemic examination like CNS, CVS, RS, and breast examination are within normal range. And my indirect laryngoscopy is normal, and both vocal cords are normally mobile. To summarize my case, my patient is 29 years, clinically thyroid female with 4 into 3 centimeter size, painless, solitary nodule in left lobe of thyroid for past 1 year, with no cervical lymphadenopathy and no compression features.
So, what's your provisional diagnosis and differential diagnosis?
My provisional diagnosis is solitary thyroid nodule, and I would like to further evaluate. And other differentials I would like to keep is which is less likely parathyroid adenoma or lymph nodal mass.
Right. So, what would you do next?
Sir, I would firstly like to go for thyroid function test.
Zalak just wanted to add certain thing in summary. I'm sorry, because of video, I'm not visible, but then you said summary 4 by 3 centimeter size painless solitary nodule. Do you want to add anything here? At least you should add without retrosternal extension clinically, right?
Yes.
That is one. Okay, carry on.
So I'd like to firstly go for thyroid function test for my patient.
And why? Why is it so important?
Sir, if mainly in thyroid function test, TSH is most important function. If TSH is suppressed, then there is chances that this nodule is hyperfunctioning, and I would like to go for isotope scanning. And if it is, if patient is if TSH is within normal range or it is elevated, then there is chances that it is hypofunctioning and there is colloid nodule or chances of
No,
malignancy.
listen. You are going from thyroid function test to directly isotope scanning. You don't want anything in between.
Sir, I would like to add USG next.
Why?
Sir, from USG is having very good sensitivity to pick nodule with high risk features, and according to that, we can evaluate further.
So which USG will you ask for?
USG next, sir,
With what?
with color Doppler.
And high frequency probe, right? That's very much important for the thyroid to be delineated. So which features would you like to see in the USG?
Sir, I would like to see consistency of nodule, whether it is cystic, solid, or spongiform. I would like to see for any echogenic foci. Other is margin, whether it is regular, irregular, or whether nodule is taller than wider. I would like to see.
First of all, you would like to see and confirm your diagnosis, whether the swelling is arising from the thyroid or something else, right? That is first. Okay? Zalak, you are directly jumping to the thyroid. You don't want to confirm it by the investigation. So first and basic investigation for you is the USG neck to confirm the diagnosis whether tumor is or swelling is arising from the thyroid. Correct? And then what you said is pertaining. And you said something about the lymph nodes? I think yes. You will see for the lymph nodes, right?
Yes, bilateral cervical lymph node.
So you did TFT and USG neck. Now what else?
Sir, after USG neck, if it is high risk features, I would like to go for fine needle aspiration cytology from the nodule.
And if there is no high risk feature, then?
Sir, then also, if it is intermediate risk, if it is purely cystic, then there is no role of doing FNAC. But if it is low risk features, there is size criteria for low risk features. If it is more than 2 centimeters, then we should go for fine needle aspiration. And for intermediate risk feature, for more than 1.5 centimeters, we should go for FNAC. And for high risk, more than 1 centimeter.
So which are risk factors?
Is size always important, or is there anything else that will guide you regarding FNA?
The size and characteristic of nodule, both are important.
Is there any neoplastic lesion which will be not taller and wider, taller than wider?
Sir, follicular variety of differentiated thyroid cancer, it is rounded. Focus in rounded.
So which are T-right category, Zalak? You know something about T-right category?
Yes, sir. Thyroid is USG finding of thyroid nodule, and it is divided from benign to highly suspicious lesion. And thyroid 1 is having a normal thyroid gland. Thyroid 2 is benign appearing nodule. Thyroid 3 is suspicious, and thyroid 4 is highly suspicious, and 5 is.
Sorry, carry on. Is there any subcategory for?
Yes, sir. Thyroid category 4 is subdivided into A, B, and C according to thyroid features. If it is one feature is there, then it is thyroid 4A. If there are two features, then it is 2 or 3 features, it is thyroid 4B. And if it is 4 features, then it is thyroid 4C.
One is A, 2 is B, 3 to 4 is C, and then more than 4 is obviously.
All 5 is thyroid 5.
So what next? You have done ultrasonography. Anything that you found on this patient?
Sir, my patient actually presented to us with CCT neck, which was carried out outside.
So the patient didn't have an ultrasonography. She had a CT scan up front.
Yes, sir, upfront. She came from outside.
What
Her
is-
thyroid function test, which was normal.
If
And
she had come
these
to you, if she had come to you, would you have done the same?
No, sir. If she has come to me earlier, then I would like to firstly go for USG.
And in which case would you do a CT scan?
Sir, if it is appearing there is compression features or there are multiple lymph nodes enlargement bilateral cervically, or if there is retrosternal extension, or if there is, I suspect any tracheal invasion, then I would like to.
It's only taken infiltration, or are you worried about something else also?
I could not.
Yes, anything else?
Sir, if there is also, I can go for MRI if I suspect there is esophageal
What about
infection.
from trachea? Mention of taken infiltrated. What are the other adjacent structures?
Pardon?
Apart from trachea and larynx, is there anything else that can be infiltrated?
Sir, esophagus and vessels, great vessels, carotid artery, and internal jugular vein.
Right. Space for, especially for supramendial lesion, you can have parapharyngeal infiltration also. So what is better? CT scan to find out infiltration.
Sir, for parapharyngeal invasion, I would like to go for MRI.
And also for esophageal and vascular infiltration. If you suspect an ultrasonography, yeah, MRI is better. For trachea is this can is okay. So this patient had a CT scan. Anything that you want to mention that you found?
Sir, on I would like to comment on scan. It is contrast enhanced CCT scan of neck and upper thorax, and there is heterogeneously enhancing lesion over left lobe of thyroid, which is having some cystic areas also with well-defined margins, and it is abutting great vessels at some point. And trachea appears mildly deviated to left side. Sorry, right side.
So it's about carotid vessel.
Yes, sir.
Right. We are playing there's no there's no retrosternal extension.
No, sir. There is no retrosternal extension on.
What would you do now? The CT scan in front of you, you have the patient.
Sir, I would like to go for fine needle aspiration cytology from the nodule to confirm my diagnosis.
What sort of needle would you use? What size of needle would you use for FNA?
Sir, according to FNAC report, it is features are suspicious of papillary carcinoma of thyroid. This is means Bethesda category 5.
I think you didn't catch my question. What size of needle would you use? And second question, whether you should do ultrasound guidance or you can do blindly.
Sir, I can go from blindly also in this patient, as it is very big nodule, and I'll use 22.
No, Jalak, listen, Jalak, be specific. What will you do? Sir is asking you, will you go blind or will you go USG guided in this patient? You have CT scan, okay? That is a good point for you now. and you read the report. What will you do here?
Sir, I will go blindly.
Why?
Sir, it is large size of nodule, and I can easily directly go for FNAC.
No, there are few features as well. Is it heterogeneous, homogeneous? Is it mixed character? That you have to see and then decide. I mean, just because it is palpable, you cannot go blindly.
So
that is one. Second, sir, ask you which needle will you use. That is very important.
Sir, 22 or 23 gauge needle. I would
Is it for 22 thyroid? Never.
23.
Yes, sir. Please carry on.
When
Dr. Arnab.
Yeah, when would you say the distribution 5 or 6 cells?
Pardon, sir, I cannot.
There's some problem at your end. Can you hear me? When would you say you have adequate sample?
Sir, I would like to have 6 passes of needle, and each containing approximately 10 to 15 cells. That is called adequate.
Okay. What is orphan
Often any appearing nuclei, it is seen on FNAC on histopathology after staining, and it is inclusion bodies which are without any nuclear any cell features. What is called orphan anemia.
Orphan Annie is a cartoon. The orbit. There's a similar appearance that you see on FNA. The nuclear, the cellular, they allow normal obviously, and the normal is difficult to better seen on FNA of the HP. Those chromatin, nuclear, they might be overlapping, they might be intranuclear. Basically, it looks like orphan any cartoon where the nucleus is periphery. Anyway, you carry on.
My patient underwent for USD guided FNAC, and it is suggestive of suspicious of papillary carcinoma of thyroid.
So what will be the test of what?
Sir, it is practiced 5 features of suspicious for papillary carcinoma.
Okay. Advice to the patient. What would you advise?
Sir,
you have seen the patient. What would be advice to the patient now? Any other
sir,
do you think any other imaging at all?
no, sir. I would not like to go for further investigation. I would like to counsel my patient for total thyroidectomy.
Any role of PET CT scan?
Sir, as such, it is confirmatory of. It is highly suspicious of malignancy. There is no role for PET.
Zalak, which are pre-operative investigations you said? What I heard with some audio disturbances is only TFT. Is it so, or you want to add something?
Sir, pre-operatively, I would like to go for
no,
pre-operative.
for disease, pertaining to disease. I'm not talking of pre-operative blood investigation.
But the thyroid function test, I can go for calcitonin if it is suspicious.
No, what you don't say can. What will you do once you have FNAC features suggestive of suspicious papillary carcinoma of thyroid?
Sir, if it is suspicious of papillary carcinoma of thyroid, so I would not like to go for calcitonin, but I would like to go for serum calcium level pre-operatively, and uh, also albumin level pre-operative.
And no serum thyroglobulin.
No, sir. Pre-operatively, there is no role of serum thyroglobulin.
And
Name one situation. Thyroglobulin done. So it's not recommended. You're right. Pre-operatively, beforehand.
I think Arnab, your voice is little breaking. Maybe bandwidth. Maybe you can switch off the video and keep audio. A little bit voice is breaking in between.
I'm sorry. Right.
no, I think Dr. Somshekhar, it's all there's some problem in audio also. I'm also not getting him, and not even to Zalak.
I can hear Zalak. It might be my problem. So I've switched off my video. Is the audio any better?
Yeah, now significantly better.
Very good. What I was asking, is, there might be one or two situations you have to do it routinely. You're right, you don't do it routinely. One of the situations. Say, for example, a neoplasm or a swelling of the thyroid is got a FNAC done. The follicular neoplasm is not
So base.
or skeletal.
So Dr. Arnab, you are not audible. Yes, yet.
Anybody? I'm sorry. Right. Switch on to Bluetooth if you want. You carry on. I'll just sort out myself.
So what Dr. Arnab wanted to ask is, in which situations, or are there any indications for going for serum thyroglobulin beforehand?
If I am planning for hemithyroidectomy, then I can consider for serum thyroglobulin pre-operatively to
So, what is the role of serum thyroglobulin here, Zalak? Because now you have FNAC. Why do you want to go for serum thyroglobulin at all?
Serum thyroglobulin, sir, if there is no visible thyroid lesion, and if there is suspicious node, I would like to go for FNAC from that node and thyroglobulin wash out from node to check whether it is originating from thyroid or not.
So thyroglobulin is not only diagnostic marker. It has something for the prognosis, and second is for the follow-up of the patient, right? Is thyroglobulin alone is important, or you will advise something else along with it?
In post-operative period, I would like to go for the serum thyroglobulin along with anti-thyroglobulin antibody.
Why?
So sometimes thyroglobulin is not raised, but thyroglobulin is mainly produced by thyroid gland. So if there is residual lesion or any metastasis from thyroid, it will produce thyroglobulin. But sometimes if along with anti-thyroglobulin antibodies, they will destroy thyroglobulin, and that will be the low level is false. Increasing anti-thyroglobulin antibody is also significant.
Any role of any molecular diagnostic? May not have all the time, but
sir, if it is suspicious, then there is rule in or rule out molecular diagnostic testing. But for my patient, the rule in diagnostic testing is having a high specificity and high positive predictive value. So it will it will more specifically suggestive of malignancy in benign or borderline appearing nodule, and rule out testing is more towards benign condition. It is having high negative predictive value.
So which test will you advise? Molecular test.
So for my patient, I would not like to go for
Okay, but if in a doubtful cases, if it is, so what is the Bethesda category? Here, I cannot read anything in this report of about the, because it has written suspicious of papillary. Ideally, he should have given Bethesda category as well.
So Bethesda has divided into 6 categories, which is Bethesda 1 is unsatisfactory or non-diagnostic. In such cases, we have to go for repeat FNAC. Bethesda 2 is suggestive of benign conditions. Bethesda 3 is ATP of undetermined significance or follicular ATP of undetermined significance. Bethesda 4 is follicular neoplasm. Bethesda 5 is suspicious of malignancy, and Bethesda 6 is confirmatory of malignancy.
So, in which condition of Bethesda category will you advise rule in or rule out test?
Sir, in Bethesda 3 and 4, I would like to go for ruling genetic test.
So, which test will you advise?
Sir, for Bethesda 3 and 4, if I'm planning for hemithyroidectomy, so if it is for that, I would like to go for rule out test, but I want to be sure that I am planning for total thyroidectomy and it is malignancy, then I would like to go for rule-in test.
So, which test? Which is available in the market? That's what I would like to ask. And what is the turnout time?
Rosetta,
Okay.
Thyroid version is available.
Okay. So, Afirma turnaround time is how much? But that's fine. In thyroid nodule, there is no hurry. You can say that I will wait for, right, for the Afirma report to come. But what is the turnaround time that you should know in the Indian scenario? Anyway, in this condition, you said the size of nodule is 4 by 3 centimeter. Am I right? Hello, Zalak, are you getting me?
Yes, sir. 4 into 3 centimeter.
4 into 3 centimeter with suspicious PTC and without retrosternal extension, and there is no lymphadenopathy, 29-year female. So, in according to ATA, this patient falls in which risk?
Sir, this patient falls into low risk category.
In the low risk, right? Okay. So, first of all, once the diagnosis of thyroid carcinoma comes, you must put patient into risk category. And that category will define which type of surgery will you advise. That is very much important. Not all PTCs or not all DTCs will go for the thyroidectomy, total thyroidectomy. So here, what is your further line of treatment?
I would like to go for total thyroidectomy for this patient. I would like to firstly go for counseling of this patient. And
did you do the workup in form of, you want anything to add other than CT scan of neck and chest? Because neck and chest is there with you, that's why. Now, do you want to add something? You said I'll go for the TFT, serum calcium, anything else before surgery other than pre-operative workup?
Sir, I have already examined indirect laryngoscopy, but intraoperatively also before putting patient under general anesthesia, I would like to see for vocal cord modulation.
Okay.
Nowadays, people talk about PET scan.
Sorry, sir.
Is there any role of PET CT scan at all?
Sir, PET CT scan as such in differentiated thyroid cancer, it is very less role as if there is uptake in PET CT, only 30% chances that it can be malignant. So there is very less role.
True. So what is flip-flop phenomenon? What is flip-flop phenomenon? Am I audible?
Flip-flop phenomenon. It is as differentiated thyroid cancer. They uptake isotopes. They uptake isotopes, and they are well seen on isotope scanning. But as they go from differentiated to undifferentiated type, like anaplastic, they will not uptake isotopes, and they will appear brighter in PET scan. They will uptake PET.
Very good. Find PET CT. Because of them would be malignant. Otherwise, it's routinely recommended for sure. Just something you might have picked up during PET CT scan for other things. This is not getting a PET CT scan done for thyroid neoplasm. Am I audible or you still having problems?
No, I think Dr. Arnab, you are still not audible.
I'm so sorry. I don't know what to do.
Is it so? In between, you are nicely audible. Then in between, the connection or your voice goes off.
Okay.
So Zalak, important nutshell, you will do PET CT here or you will not? 29-year female, nice nodule. Will you go for PET CT here?
No, sir.
Okay. But at least you should add USG abdomen. That's what I feel. Okay. So fine. Now you have fully worked up the patient. Which counseling would you like to do with the patient?
Sir, I would like to explain risk pertaining temporary voice change, and there is chances of temporary hypocalcemia for this patient.
What is the percentage of temporary hypocalcemia?
The temporary hypocalcemia occurs in around 10 to 20% of patients.
And change in voice, you said something.
Yes, sir. Because of manipulation of recurrent laryngeal nerve, there is chances
So
of.
how much percentage?
Temporary, it is 10 to 20.
Is it so? It is less. Anyway, but then what will you explain patient? The change in voice in which format?
That voice will be heard for some time, and gradually it will improve.
Okay. Will you explain something about external branch of superior laryngeal?
Sir, as it is most of time it is safeguarded, and it will not come into picture. But as my patient is having mainly left-sided disease, there is less likely that she will have aspiration.
And if it is right-sided, she will have more?
So unilaterally, she will have.
So that is what one thing, because it is not bilaterally enlarged thyroid, chances of external branch injury or for that matter RLN is less than 5%. Okay. However, still there will be some temporary change in voice because of manipulation of RLN. That is one. Second, because of some local edema undergoing after surgery. Two. Right. So you did ideal scopy and you explained and counseled the patient. What would you like to do here?
I would like to go for total thyroidectomy for my.
You said it is low risk according to ATA.
Yes, sir.
Then
Sir, we can consider for hemithyroidectomy also in this patient, as she is having a 4 centimeter. For hemithyroidectomy, we can safely go in low risk category less than 1 centimeter. But for 2 to 4 centimeter size nodule, it is debatable. Both are for two, even if I will find some high risk features on final histopathology, then I would like to go for remnant ablation with radioiodine. So for that, I would like to go for total thyroidectomy. Otherwise, I have to put my patient for another surgery, second time surgery.
So patient is female, 29-year-old. You didn't ask about the obstetric history, and you didn't counsel anything about.
A patient is having 2 children, and she's married for 10 years.
Okay, fine. So otherwise, if she wants,
Total hemi and total thyroidectomy. Am I audible now?
yes, partly yes.
I'm still right. No, there was a recent meta-analysis where looking at 13 different studies published by Zhang et al. And they are recommending anything more than 2 centimeter go for total thyroidectomy, and that's going reference with thyroidectomy.
So Professor Arnab, you are still not audible.
I'm so sorry.
So if Zalak, are you audible? I mean, am I audible to you? Zalak, am I audible?
Yes, sir, I can hear you.
Yeah. So now if, okay, now in this patient, it is G2, P2, that's fine. But if patient is having, I mean, she wants to bear the child, what will you counsel her?
Sir, I'll tell her that if she can wait, then firstly deal with thyroid condition, and then I would like to see for final histopathology report, and if whether she will require radioiodine remnant ablation or not, and if she is not requiring ablation, then she can plan child after 6 or after completion of radioiodine treatment for at least 1 year. She has to wait.
Right. So that is very much important part of counseling, okay? Because majority of thyroid carcinoma patients are female, they are sometimes young, and you must explain this also. So you said, okay, now first we'll go for the treatment. You did total thyroidectomy. What else? I mean, is your surgery over or you want to add something?
Sir, there is role of central compartment lymph node dissection in T3 and T4 cases, or if any lateral lymph node and laterally enlarged lymph node. But in my patient, it is T2, and there is no lymphadenopathy on scan. So I would not like to go for dissection, but I would like to go for central compartment exploration for my patient.
So how will you explore central compartment?
So
I
the
don't
central
know anything
compartment,
like exploration.
sir, I like to dissect along the recurrent laryngeal nerve, and if any enlarged or suspiciously looking lymph node is there, then I would like to dissect.
Otherwise, you'll not. So what is the clinical specificity and sensitivity of your finger to palpate the enlarged node?
If it is more than around 8 to 10 mm, then it can be fixed.
So basically, Zalak, I would like to add on here because it is 4 centimeter. Again, it's kind of a borderline tumor between T2 and T3. And here I will strongly recommend you to go for the central compartment. If anything, something like 2 centimeter nodule you would have, and if it is on table, you are very much damn sure that things are okay, then things are different. But here in 4 centimeter suspicious nodule, you will definitely address the central compartment, right? Now she is 29 female and it is the FNAC is suspicious PTC. Would you like to confirm your diagnosis on table before going for total thyroidectomy?
By frozen section, no, sir. I can, as on the scan and on FNAC, it is highly suspicious. So I can go for a total thyroidectomy. And there are also, it is papillary thyroid. So there are chances of opposite lobe can harbor small micro nodule.
So is there any role of frozen section in papillary thyroid carcinoma? That's what I want to ask.
It is for to differentiate follicular adenoma to follicular carcinoma.
Do you think
What?
Do you think frozen section can differentiate?
What, frozen section?
No, sir. It is, I can, sorry, sir. For follicular neoplasm, it will be differentiated on final histology.
So is there any role of frozen section in papillary thyroid? See, all things go around because she is a young female, right? And you want to give her least possible morbidity and still you would like to address the disease in a proper fashion, right? So that's why even serum role of serum thyroglobulin, serum TG antibody comes here and addressing the level central compartment lymph nodes, right? So the FNAC is suggestive of suspicious PTC. Clinically, you think it's like there are no features suggestive of patient goes into low risk. Will you repeat FNAC or would you like to review the slides?
Sir, I can go for surgery directly. It is suspicious for papillary thyroid carcinoma.
Because there is no Bethesda category written in the cytology also, which is to me not adequate report. Anything without Bethesda category report for me is not adequate. Is there any Bethesda category? I mean, what it might be, but in the what you have put the JPEG picture, there is no Bethesda category.
I'd like to go for a review of a slide.
So that is one thing. You must review such type of reports. If it is not from the authenticated laboratory or cytopathologist, I will be very wary about the taking the diagnosis. And particularly in a young female contemplating total thyroidectomy, right? Okay. So now your histopathology is.
Are you happy with
differentiated papillary thyroid carcinoma with one central compartment lymph node positive? And there is no extra thyroid extension.
Sir,
So what is the stage of this disease?
Sir, it is still stage 2 disease, as there is only as it is a stage 2 disease. Sorry, sir, it is stage 1 disease as
Yes.
stage 1 disease as she is less than 55-year-old female. All localized disease is stage 1.
तो क्या करोगे अभी? What is your next step?
I would like to see whether that node is having micrometastasis or macrometastasis. And if it is less than 0.2 mm, then it is micrometastasis. Then she still falls into low risk category, and I can put her on observation.
Okay. So does lymph node metastasis in differentiated thyroid carcinoma change the prognosis, particularly central compartment?
Sir, no, sir. Prognosis that increases risk of recurrence, but it will not change prognosis.
Particularly in a central compartment lymph node positivity, and you rightly said micrometastatic disease hardly change any prognostic value, right? So, but how will you follow this patient? Now you have done this, one node is positive, you don't want to do anything. How will you follow this patient?
Sir, I'd like to firstly, I'd like to keep patient on no, I will not give T4 ultroxin in this patient for 6 weeks, and then I'd like to go for scanning after 6 weeks with radioiodine, which is 1 to 3 millicurie, and after that, I would like to start ultroxin to this patient if it is low risk patient, low risk category, and I'll add serum thyroglobulin in follow up.
So, what is thyrogen? If you want to do thyroid scan, patient is overseas, wants to go and travel something, can you do something within a week?
Yes, sir. I can give recombinant TS. I can give patient recombinant TSH for 2 days, and on third day I can directly go for scanning. For scanning, I would like to have the serum TSH level more than 30.
Is it possible in your case? Your patient has undergone CT scan with contrast or without contrast?
Sir, with contrast. So, sir, my patient will not. She will not be able for some time.
Why?
Because
What is
contrast.
that phenomena called?
That is called thyroid stunning.
Yes. So what is it?
Sir, contrast is having iodinated contrast. So when excessive iodine we give to patient, it will cause thyroid stunning. And thyroid gland will not uptake for some time further iodine.
Thyroid gland is not there. You anyway removed it. So any thyroid avid tissue will not uptake your radioiodine for how many weeks?
6 weeks.
4 to 6 weeks. Okay. After 4 weeks, you can go for the radioiodine scan. So in this case, recombinant TSH and go for immediate radioiodine scan, diagnostic or therapeutic is not possible, ideally. And you have to wait, you stop altroxin, don't start it, and for after 4 weeks, you go for the serum TSH. What is minimum level of serum TSH? You can go for the radioiodine scan.
Sir, it is more than 30.
At least more than 30.
What is the other option apart from recombinant TSH?
Sir, I can put on. Sir, for I can put my patient on three means T3, and then after 2 weeks I can go for.
Okay. So now that is the thyroid scan is showing some uptake in the tumor bed. What will you do?
Sir, for that I would like to give 30 millicurie radioiodine after 2 days to this patient.
So what is that 30 millicurie radioiodine is what?
That is radiation we are giving to thyroid gland
So how will you give radioiodine?
orally. Mm,
By means of
uh,
which advice? I mean, the 30 millicurie is what? Which dose it is?
it is radiation dose.
So it is low dose, Jalak. It is low dose radioiodine. You will advise your patient, okay, for ablation of remnant tissues in the tumor bed. That should be your answer. And low dose radioiodine doesn't require any hospitalization, right? So what is high dose radioiodine?
High dose radioiodine is more than 100 millicurie, and
Okay.
for that patient needs to be hospitalized for at least 8 to 10 for 1 week.
Okay. What is the highest dose of radioiodine you can in one go give?
So we can go for around 200 to 250 millicurie, but also 300 can also be given, but it is having high toxicity.
Which toxicity will you contemplate?
So mainly it will cause dysphagia, then cheilodinitis, then dry mouth. It will cause. And
Okay,
with
so
high
what
high
is the
dosage,
maximum dose of radioiodine body can withstand, Jalak, in a different dosing?
so it can withstand up to 1000 millicurie.
Is it so? You can give up to 1000, but anything above 600 millicurie is toxic to the body, right? Ideally, you should not cross 600 millicurie. Okay, now one. Radioiodine scan is showing some uptake, and at what time will you give therapeutic low dose radioiodine? You have done today radioiodine scan.
Sir, then the day after tomorrow, I'll like to give therapeutic.
Why not after 10 days?
Sir, then the that low dose we have given that will be uptaken by the remnant tissue, thyroid containing tissue.
So again, there
And
will be thyroid stunning,
thyroid.
right? So whenever you do diagnostic scan, you should have therapeutic dose within a week. Okay. So refer your patient for diagnostic radioiodine scans only to those centers which have the facility for this. Now we are doing something at Surat where the radioiodine diagnostic scan is there and they don't have therapeutic facility. Ideally, you should not do, because then patient you will advise something, will go to higher center and it will take time. Okay. So before advising post-operative radioiodine scan, you must keep in mind. Will you go for serum thyroglobulin now or still you don't want?
Sir, I'll after surgery, I'd like to go for serum thyroglobulin for
Okay,
baseline level and then follow up.
now everything is fine. You have given remnant dose, serum thyroglobulin is within normal limit, serum anti-TB antibody is normal. How will you follow this patient?
Sir, I would like to start altroxin to this patient, and keeping in mind that I would like to keep PSH between zero point 0.5 to 2 million unit per liter in that range. And I would like to follow every 6 monthly for first year, and then if patient is still in low risk category, then I'd like
Last
to
question, Jalak, because of time constraint. Thyroid radioiodine resistant metastatic PTC. How will you treat?
radioiodine resistant PTC, we can challenge with radioiodine again. And if it is still not picking, then we can go with TKI, tyrosine kinase inhibitors, or
Which one?
external. We can go for sorafenib.
Something sorafenib in thyroid. Okay. What else? And what is the response rate of TKIs in radioiodine non-avid metastatic differentiated thyroid cancer?
Sir, it is around 30 to 40% response rate is there, and it is also highly toxic. So I can go if it is there is bony lesion.
What is lenvatinib?
Lenvatinib it is also yeah,
Okay.
we can
Can we continue, Dr. Somshekhar, or I mean, then I can
Maybe
ask
we'll open the questions and answer a bit for them now.
Yeah, so that's why.
So that we can, yeah.
So you can take over, Dr. Somu, or I should continue?
No, you please continue.
Yeah. So now, if this the final histopathology has come de-differentiated carcinoma of thyroid, what will you do in this case? Because you have suspicious papillary, you didn't verify it by repeat FNAC or going for the frozen section, and now you are in SOAP.
de-differentiated.
You did total thyroidectomy, you didn't touch central compartment because you never wanted to.
So then I would like to go for central compartment.
Okay, then what? In a de-differentiated thyroid carcinoma, because papillary can go into de-differentiation.
So then also I would like to go for a radioiodine scan, and if it is uptaking, then I would like to go for radioiodine.
So here Professor Arnab's question comes, the role of PET-CT, yeah. So first thing, sir, I'll go for post-operative metastatic workup in the form of PET-CT scan, and I would like to see for the PET-CT avid lesions in the body, locally as well as the distant part of the body, right? So the more de-differentiated thyroid, the chances of PET-CT uptake is high. In which condition will you go for both radioiodine and PET-CT?
Sir, in such patient, if initially it is papillary and it will go for de-differentiation, or in follow-up patient which was previously taking uptake of radioiodine and stop uptaking radioiodine, I'd like to go for both.
So what is ATC? Tell me.
ATC is anaplastic thyroid carcinoma.
So what will be the difference in the management of ATC? At outset, this is not the feature suspicious of PTC. It is suspicious of anaplastic thyroid carcinoma. What difference will be there in the management? The same nodule and everything. Tell me something more.
Sir, anaplastic thyroid carcinoma is put in stage 4, 4A, B, and C. So they should be managed aggressively. I'd like to go for surgery first in that patient, and then we can also give external beam radiation.
Listen. You are directly contemplating treatment. I said, what is the difference in management as against differentiated thyroid cancer?
I would like to go for PET scan for that patient as it is anaplastic.
Will you go for the true cut?
Yes, sir. I would like to go for.
Why?
So anaplastic carcinoma, I would like to confirm by it is mainly solid part. It is having a mainly solid part. So firstly, I would like to confirm whether it is
anaplastic. Why do you want tissue diagnosis, Zalak? Important question is, why do you want tissue diagnosis here, and you never wanted it in differentiated thyroid?
Sometimes readers thyroiditis can mimic like anaplastic thyroid cancer.
So
and
that is one. Second, Which are
Other,
markers you would like to address when there is diagnosis of anaplastic thyroid cancer?
TTS1.
Repeat, I'm not getting you.
TTS1.
So, most important targetable marker in anaplastic or dedifferentiated thyroid carcinoma is BRAF V600E, right? You must know whether this is BRAF 600VE positive and whether it's negative, because management is totally different. The prognosis is totally different. Here, because it is operable, you may go for the total thyroidectomy, but otherwise majority of ATCs are not operable, and you need a tissue diagnosis for targetable markers. Which are other markers you know about the thyroid cancer? One is BRAF V600E.
Other is PTC. Other is RAS mutation.
Second most important is RET proto-oncogen, red proto-oncogen, right? It is the marker for
Medullary.
right MTC. Which are the exons you know? Which are the red proto-oncogens?
RET exon, it is having mutation on exon 9, 10, 11, 13, and on location 918 is having highest risk.
No, I don't agree with you. So if it is highest carrying risk, what will you advise to your patient with MTC?
Sir, I would like to, for that patient, I would like to go for surgery for total thyroidectomy and central compartment lymph node dissection. And also, I would like to go for genetic counseling for patient and her family.
Okay.
So,
Lakshmi, open
yeah.
a Q&A and chat and answer the question. Yeah.
Yeah. Which are the questions?
Yeah, so I will ask some question. Arpan has asked, sir, what molecular test do we do for indeterminate nodule? Is it available in India? What is the cost and what is the turnaround time and what is the sample? Is it the blood or the FNAC cytology?
Yeah, Zalak, you want to address the question? So I
Zalak,
think indeterminate nodule. Yeah, Zalak. Dr. Samu, please.
yeah, Zalak, you understood this?
No, sir, please.
Now, are you aware of this? If we have an indeterminate nodule, a patient says, I don't want to undergo a surgery frozen to no benign malignant. If it is benign, I want to leave it. So you have a molecular testing available to roughly distinguish malignant and benign. So which molecular test do we do? Number one, what do you send? Blood or FNAC tissue? Number three, what is the cost and what is the turnaround time in India?
Sir, FNAC tissue I would like to send, and I'd go for rule out test if I want to prove it is benign. And cost.
What's the name of the test? What molecular testing?
Sir, Thyroid version 3.
And what is the cost? What is the cost? Turnaround time? How much time it takes? That.
7 to 10.
Okay, it takes about roughly 7 to 14 days in India. It is 1.7 lakh rupees in India. Okay, I hope Arpan it answers that question. It is available in India. Then second thing, somebody asked, what is the difference between anatomical total thyroidectomy and embryological total thyroidectomy? If you just do anatomical total thyroidectomy where right lobe, left lobe isthmus you remove, you leave thyroid tissue in following place. Number one, thyrothymic ligament. Pyramidal lobe is a part of the distal remnant of the thyrothymic ligament which arises from the junction of isthmus and the left lobe, ascends up to hyoid. So it is a embryological remnant which is always there, pyramidal lobe. So if you leave that, when they do iodine scan after your surgery, they would say there is a prelaryngeal delphin lymph node falsely, and they will upstage as a node positive, and the dose of iodine will change, when in fact you have left the normal thyroid there. So that is one part of the embryological thyroid. Second, tubercle of Zucker candle. It is type 1, type 2, type 3. Please read the anatomical variation of tubercle of Zucker candle. That is at the cricothyroid ligament, where you de-roof the recurrent now at the division of the anterior posterior division of inferior thyroid artery. You leave a tissue. So 50 number D9 dissection, not to leave a tissue there. Otherwise, they'll report as a nodule and lymph node in the tracheoesophageal groove, and they will upstage. Third.
Or sometime remnant there. After the total thyroidectomy.
Yeah, normal remnant you will leave it. So number 3, the thymus and the inferior parathyroid develop from the same embryological origin. So a thyroid tissue will also be pulled along with that between the isthmus and the thymus, thyrothymic ligament. So if you do anatomical thyroidectomy in malignancy, you will leave normal thyroid at this place: pyramidal lobe, tubercle of Zucker candle, thyrothymic area. So a embryological total thyroidectomy for malignancy means not just right lobe, left lobe, isthmus. You remove the entire thyrothymic ligament, tubercle of Zucker candle completely, and chase and remove the pyramidal lobe up to hyoid. I hope this answers the question. This is an embryological total thyroidectomy. There are a lot of questions. I think we may have to end. It's already we overshot by 15 minutes, but it's a beautiful discussion. Thank you very much, Laxmidhar. This shows that there is a lot to learn in thyroid. Maybe one more session and one more presentation we will do. Zalak, you did very well. You actually withstood all the questions that is asked. If I was there, I would have failed long before. Very good.
Somsekhar, you rightly pointed out, because thyroid is very heterogeneous. It's kind of a breast cancer. One side is very, very prognostically good, and another side is so bad that sometimes we get havoc. And even we being a surgeon, we feel that certain thyroidectomies are quite like peanut easy, and certain are so tough and difficult for us.
Correct. And then remember, Zalak, where students fall down in exam. Test, clearly understand which in order: ultrasound, FNA, and thyroid function test. Please understand that. Image guided and blind. These questions are there. Bethesda classification, TIRADS classification. TIRADS 3, Bethesda D, what will you do? Please know that. Then next trap is frozen section. Then CT scan versus MRI, with contrast, without contrast. Okay. Radioiodine, oral, IV, liquid, tablet form. Please read that. Thyroid scan, do you use technetium or iodine for diagnostic? Please look at it. Okay. Then recent ATA guideline of titrating dose of thyroid tablet to keep the TSH. TSH is a W1 class 1 carcinogen. It needs to be kept low. So ATA guideline. If it is T1, N0, M0, what is the TSH range as per the ATA guideline? If it is node positive disease, what is the guideline? What should be the value of TSH? If it is a metastatic in lung bone, what should be the TSH? Please read this. This question will come and I will be asking this. Okay. Then central compartment boundary. When IJV to IJV or carotid to carotid. 2 questions I ask, all the students fall down there. Please read beyond doubt. What is the boundary? I always ask this question. Central compartment is hyoid to division of left innominate vein. Right boundary is what? I ask, is it carotid to carotid or is it IJV to IJV? Nobody answers this because you're not read. Please read that. Okay. And what is the first echelon lymph node? Role of SLNBs. And then cumulative dose of radioiodine 1 can be given in the entire life. If there is a lung metastasis, what is the maximum dose you can give to prevent fibrosis? All these questions will come, and unfortunately I have to answer all to pass, not to get gold medal. Okay. But you did very well. You will pass definitely. All the best. Okay. Thanks, Laxmidhar, and thanks, students.
Thank you, Dr. Samsekhar.
Thyroid again. Laxmidhar, fantastic. And thanks also to Arnab.
My pleasure. But Samsekhar, I must owe you, not only appreciate, I must owe you, because you are taking a lot of pain for the students. And I mean, it's kind of a professorship from you that I'm really, Chefut wala shat naman. Thank you.
Thank you very much. My honor. Students are benefited. That's why I continue. And thanks to NBMS and over to our coordinator.
Okay. Thank you, Dr. Samsekhar, Dr. Murtuza, Dr. Arnab, and Dr. Zalak for your time. And we now close the session. Thank you.
Bye-bye.
Thank you.
Bye. Yeah. Thank you.
Yeah. Thank you. Bye.